Good morning, everyone. It's very nice to meet you all and to be here this morning. I must thank you for that suspiciously gracious introduction. It's longer than it should be, but look, it's a real pleasure to be with you this morning and to discuss a number of important issues, but most pressingly for the moment, I suppose, safe staffing levels and some perspectives that we would have around that. And the manner in which I've chosen to address this, I think, is to just point out to you a little bit of what we view as important on your behalf and what the feedback has been from our members in relation to the importance of safe staffing to safe practice, to talk to you a little bit about what the research says, which I think will be very readily identifiable with your day-to-day practice on the importance of safe staffing, to talk to you a little bit then about what we're doing currently to improve the situation, what work is underway, and to be quite frank with you, what work we're going to have to undertake and plan to undertake in the very near future to advance matters. So I have a presentation. We'll try and move through it as best we can. The three pillars of any safe staffing regime or standard within any healthcare environment involves a complex mix of factors, but the three most pressing ones identifiable from the research, and certainly the more recent research, is the number of staff who are available within the ward. Perhaps more importantly than the number, the skills mix of that staff, having the right people available with the right skills in the right environment at the right time to provide the right care. And then the practice environment, the more unstable the practice environment is, and a lack of leadership within that environment is also very concerning and very influential in relation to the delivery of safe care and the provision of safe staffing. But moving on to look, the current staffing levels in Ireland are determined in a kind of a ad hoc, I suppose, would be the kindest way one could probably put it, way to date. They're largely historically determined. There have been many different factors over the years which have determined the level of staffing in any particular unit. Now, I am referring to nursing as I go through the presentation. Obviously, when I do so, I'm referring to nursing and midwifery, but in particular around nursing, the main determinants of current staffing levels, first and foremost, is money. We currently have we've lost 5,000 nurses out of the system since 2009. It's the largest, it's 13% of the nursing workforce is gone. In that time, levels of activity have increased, presentations in emergency departments have increased, throughput in every hospital has increased, and the demands are quite extraordinary. Money has caused a significant drop. We have moved back maybe 1,000, so we're about 4,000 below where we were previously, and that affects everywhere. It affects every division of the register in terms of those working in the system, and it affects midwifery as well. But the other factors which have historically determined staffing levels would include intuition, what was thought was necessary, historical practice. We always had 3 in the morning or 4 in the morning and 3 in the afternoon, which that's what we're supposed to have. Leadership. Some wards with strong leaders have maintained very strong staffing dynamics over the years because, if we're quite frank about it, more senior managers were afraid to take staff off certain managers, whereas others who perhaps were more amenable to the cuts lost staff, and that's a reality of day-to-day practice that you'd all be familiar with. And some science then. I don't want to say that everything has been totally ad hoc. There have been some science efforts to do that, and what I mean are tools that have looked at dependency, acuity, environmental factors and other issues which affect the level of staff that are required and the skills that those staff should hold. And most of that science work has been pushed really by staff demanding in many locations improvements, and to make the case for improvements having to get outside experts in to review staffing levels in individual locations. Well, what do we need? Well, we need, going forward, some sort of scientific determination of staffing levels in all environments. We can't demand the rigours of spending and accounting control and scarce resources mean that it isn't sufficient to say that you require something. You must show that you require it, and we will show that using evidence-based tools which look at acuity, dependency and practice environments. Those need to be reassessed, and staffing needs to be matched with activity levels and dependency levels on an ongoing basis, and those should be enshrined as minimums at the very least, either through legislation preferably, or certainly initially through a collective agreement. Now, the current challenges are quite frankly, the political commitment currently doesn't exist to adequate and safe staffing within our health services. The political commitment doesn't exist currently to adequate and safe skills mix, and if the commitment even were present, if we're honest with each other, we wouldn't have the resources to meet it. If we had an agreement tomorrow that we would introduce what we would view, or what you would view as safe staffing tomorrow, we wouldn't be able to fill it because we can't fill the vacant posts that are currently available in the system, and we are suffering an acute nursing shortage and midwifery shortage at present, particularly in nursing. But just talking about why safe staffing is important, because it's easy and rhetorical for others to say that you always want more staff just to have less work to do. Well, that's not really the case, because all the research will show us that inappropriately low staff numbers, and in particular inappropriately low skills mix, has a very poor impact on the care environment and indeed on individual patients. Greater levels predict, if we have greater nurse staffing levels, the research shows us that we have lower inpatient mortality, we have lower rates of failure to rescue, and a shorter length of stay. If we have higher levels of nursing hours per patient, again we have lower inpatient mortality, lower incidence of failure to rescue, and lower levels of missed care. If there's instability in a staff group, funnily enough, and this isn't something we think an awful lot about, but you will immediately, I would have think, as nurses and midwives working in hospitals and care areas and units, and you'll know, if there's a constantly changing staff group, if you're constantly being moved from ward A to B or area A to B, there is an instability in the environment, and the care environment suffers. And if it's constantly reliant on agency nurses who are doing their best, but they're coming in fresh every day, they don't know the area, they don't know where the medication is, they can't give the IV medications, all those types of things, which puts pressure then on other colleagues who have to double up on work. Well, that leads to higher instances of missed care, high levels of adverse incidents, higher levels of medication errors, increased fall rates. And I'm only picking some indicators. We would all understand this to be nurse-sensitive or nursing-sensitive indicators. You know what they are: tissue viability, medication, falls, missed care, failure to rescue. There are a range of headings. So when I'm talking about those issues, you know that I'm referring in an overall sense to them. Now, in terms of the patient-to-nurse ratio then, if you have higher numbers of patients per nurse, again, you won't be surprised, higher levels of failure to rescue, higher levels of complications, increased mortality, and increased levels of missed care. The skills mix issue then is equally important as opposed to numbers. And we talk here, when we talk about skills mix, we talk about the ratio of registered nurses to non-registered nurses involved in the provision of care. And the greatest driver of the reduction or the disimprovement of skills mix is, of course, cost. And we always must be sensitive of the necessity to have an appropriate skills mix, which is evidence-based. So nurses don't get to say that they can do everything to employ the maximum amount of them. But at the same time, the other side of that equation is that others don't get to dress up reducing costs in rhetorical language, which talks about care. You have to have, and we can't have a monopoly on it as nurses and midwives, but the managers who control spending can't have a monopoly either on determining what's safe care. It must be evidence-based, and we have to move it away from a sense of having to advocate constantly, so then you're getting people accused of being a vested interest, simply trying to line their own pockets. The reality is you have to wrest it back to some sort of evidence base which shows what's necessary for patients, and then seek to have that delivered. But if we have poor skills mix, you would all know, we have the reduced patient outcomes, higher staff turnover, and higher levels of delayed or missed care. The practice environment I've already mentioned to you. If there is a poor practice environment, if there's instability in work placement, there's some very interesting recent research coming out. If people have been moved in the last if there's high numbers of staff within a particular ward who have been moved within the last 3 months, are planning to be moved within the next 3 months, or feel that they may be moved, or don't know whether they will or won't be moved within the next 3 months, that actually has a very negative effect on the practice environment, which in turn leads to difficulties in patient outcomes and nurse-sensitive indicators, also poor staffing levels, unstable characteristics in the patient group. You never know who you're going to be looking after or what type of patient, constantly changing patients. You can't get settled into a particular paradigm in your work environment, that causes significant difficulties. And interestingly enough, for those who do, and there is a message developing that we should effectively dumb down the nurse management structures. I'll give you an example. For instance, in the community health organisations currently, there is an exercise underway to roll those out and develop them, which involves an effective eradication of nurse management structures within the community. It's currently the subject of negotiations, but there has been a proliferation of non-clinical, not only nursing, non-clinical managerial positions. Well, the research will show us that if you have insufficiently visible nurse and midwifery leadership at a unit and executive level, that leads to instability in the workforce, a poor practice environment, and that leads to lower achievement of nurse-sensitive indicators. And that sounds fancy, but what it means is more people die, there are missed care opportunities, and people are hurt when they shouldn't be hurt, arising from insufficient staffing levels. So the key messages are low staff numbers, poor skills mix, a lower number of nursing hours per patient, and poor practice environments. They reduce nurse-sensitive indicators, they harm patients, and they result in an unhappy and an unstable workforce. That's all good news, obviously. Now, what has happened elsewhere? Well, the international picture isn't very mixed, and of course you'd expect that because the economies and healthcare systems across the world are so mixed. But we look particularly to Australia and California. Virtually all states or all territories within Australia have mandated nursing and midwifery staffing levels. It depends. It's either a ratio of nurse to patient or it's patient nursing hours per patient day. There's a mixed formula, and California has it as well. Some have it in the way of a collective agreement, others have it as part of legislation. Interestingly, in Australia, while they haven't done it explicitly, what they have done recently is change the accreditation criteria for hospitals at the HICWA model in Ireland, and within those criteria are embedded implicitly rather than explicitly nursing sensitive indicators, which means that safe staffing levels have now also become implicitly part of the accreditation system, and that is something that we're going to have to very seriously look at. Your President's erudite message in your programme talks of the disaster which emerged in the neighbouring jurisdiction in mid-Staffordshire and the very difficult circumstances that emerged there. I'm not going to be dramatic, but if you compared the staffing levels in mid-Staffordshire to many of the areas in the Irish Health Service, I participated in a review team recently on a matter which is not relevant to here, but managers from the United Kingdom were over, and the point they made to the colleague who was beside me, I've managed difficult circumstances before, but I don't think I've ever managed anything like this. So it isn't dramatic to say that huge improvements are necessary and we need to move forward. So what are we doing? Well, progress has been made. Progress has been made on two fronts, really. One is in medical and surgical wards, and the other is in maternity, but it's underway. We've had the task force on staffing in acute medical and surgical wards. It's currently continuing its work. We started a safe staffing campaign in 2014. This resulted from the recruitment ban and the loss of the 5,000 posts. The Minister for Health responded by establishing the task force. It was established in September 2014. Membership included the INMO and all other relevant stakeholders. There was a draft report in October 2015, and in February 2016 the report was accepted by the Minister. In essence, the recommendations are to introduce a systematic evidence-based approach to nursing staffing and skills mix on all medical and surgical wards, which covers a very significant proportion of the Irish Health Service. And the use of an accepted tool, together with, very importantly, the professional judgment of a nurse leader at a local level to determine not only the levels of staff required, but the skills mix required on a particular ward, to make sure you have the requisite leadership, a supervisor who is free from clinical workload, because you cannot take a patient in a busy acute medical and surgical ward. You cannot be looking after 3 patients and managing the entire ward, and then people are wondering why the ward isn't being managed properly when you're doing the job of a nurse and a manager at the same time. The CNM1 role is to be appropriately resourced. An 80-20 skills mix is what the evidence shows is optimum, and the wards are to introduce a day-to-day process to assess, escalate and respond to missed care events. We're calling them safety clues, to try and quantify the issue. Without going through it all, because I know time is pressing, we might go forward just to say that The task force is currently being piloted in 3 hospitals. We have a difficulty, to be quite frank with you. There is no budget line in the budget this year to move beyond 3 hospitals that are considered. So there isn't currently, to be honest, it's not part of political exercise, there just isn't currently a political will to properly staff hospitals. There isn't the political will currently to address the recruitment and retention issues which currently exist within the system. So what we're doing, and we're commencing a national campaign. You will know about this. It involves midwifery, it involves public health, and it involves acute services and elderly care and ID services. And it really is about safe staffing and safe working environments. And that campaign will commence. We have our executive council meeting next week, and you'll get more detail on it. But I perhaps just, given that time is short, might move forward beyond the work that's ongoing to talk about coping with poor staffing levels. I think it's quite a lot further on through the presentation, which I'm happy to share with you. If you keep going.
Keep going.
Yeah, keep going. And again. Until you get to coping with that. Yeah, that's it. So, some things just to consider. I thought you might want a reflection on how you deal on a day-to-day basis. It's all well and good me standing here talking about what has been going on, and it is positive that we've made that progress. And I should say, obviously, in addition to the medical and surgical task force, we have a report in relation to midwifery manpower planning, and we've commissioned a report in relation to missed care in the community. So we have a lot of work done as to which tells us the direction we need to go in, and the question now will be developing the political will to move that forward. But on a day-to-day basis then, what can you do? Well, to be perfectly frank, the first thing you have to consider, if you're working in an environment that you consider to be, in your professional opinion, unsafe, and this is a serious matter, you do have an obligation under the Professional Code of Conduct and Ethics from the Nursing and Midwifery Board of Ireland to complain. It is an explicit obligation, and I have seen nurses and midwives accused of professional misconduct before the Fitness to Practice Committee because they have failed to raise a concern in relation to staffing. So it is really important, and I know that you as colleagues, you suffer from what we call complaint fatigue. Because if you've unsafe staffing, you believe, and you've had it for 3 or 4 years, you start to say, well, what's the point of complaining? And the point of complaining is, to be perfectly frank, if something goes wrong, and part of your defence when somebody tries to blame you for what has happened, and these are not dramatic stories, this is my day-to-day work, you have to be able to show that you raised your concern, and it is your personal, professional and moral obligation to do so. So use your internal risk forms, you can use the INMO statement of concern forms, but raise the issue. You have to have a record of raising the issue. Your president refers to Mid Staffordshire in her introduction in the programme. A major criticism of our profession in that context was a failure to take sufficient steps, including representative organisations, our sister organisation in the United Kingdom, failing to do enough to highlight the plight for patients and service users in those circumstances. Additionally, really, you have to consider, if you're in this situation and you want to make immediate progress, you have to consider some sort of collective response yourselves, working with your CNM2, and obviously involving ourselves then in the INMO if necessary. But the key issue really is, it is the key issue of our time. It certainly is not something I've ever witnessed in the last 15 or 16, 17 years representing nurses and midwives. The last 5 years have changed the entire face of what the issues are for our profession to a real focus on staffing and conditions in the wards. There's been low morale many times for different reasons, but it's never been. We've just finished a range of 12 meetings across the country, and I have never heard anything like the horror that many professionals are saying that they're encountering because of staffing on a day-to-day basis. But I don't want to end on a low note. The reality is we have made huge progress. Never before has there ever been a political agreement to introduce evidence-based staffing in Ireland. If we've made that progress and have that agreement in principle for medical and surgical wards, we will extend it beyond the pilot sites We will extend it into the community, we will extend it into IT services, and we will extend it into elderly care and midwifery. And that will, and this is the major agenda for our organisation, improve the practice environment, improve patient outcomes, and improve the stability of the workforce, and hopefully give you a better work environment. So thank you very much for your attention.